Dear members and Professor Kavita Rajan, welcome to the 26th online meeting of Madras Redford Doctors Foundation. Unlike previous meetings when senior doctors spoke on interesting topics, this meeting is all about the students at Madras Medical College. Two of the objectives of our foundation as set out in the Articles of Association are undertaking outreach charitable activity and supporting our college and its students. We have been doing some charitable work during the last 2 years. However, supporting our students proved somewhat difficult. Although we managed to sponsor a few students for the Royal College of Surgeons International Conference in Chennai last year, it has been difficult to assess the type of support that they will need. Recently, we had a meeting with few students and decided that the students would become part of the foundation as student members. They could then plan and request the type of support they would like, be it arranging talks on different topics or present cases for discussion with the members. To facilitate this, we are starting a student chapter of the foundation. A student subcommittee has been formed with Mr. Praveen Selvanandam, final year student, as the secretary. It is hoped that he will discuss with the other students to plan and arrange the support that they would like. I would like to point out here that in our foundation, we have very senior members in almost all specialities. I'm sure most of our senior members will be more than happy to talk to the students or interact with them when requested. It is up to the students to come and seek the support they want. We are extremely grateful to the Vice Principal of Madras Medical College, Professor Kavita Rajan, for having agreed to inaugurate the student chapter of our foundation. I know that she is passionate about medical education and makes sure that students get the best from the college. It is our hope that she will guide us and the students to get the best out of this partnership. Without wasting any more time, let me request our Vice Principal to say a few words before inaugurating the student chapter of our foundation.
So, a very good evening, sir. I thank the senior professors who have taken interest in supporting our students and enlightening about whatever the way they have to look at the cases, sharing their experience of your years, which is entirely different from now whatever is present. Like, so we have to have a balance between the two generations where now diagnostic techniques are being depended upon for the diagnosis, and the clinical acumen has been decreasing nowadays. So I wish that the professors of yesteryears would inculcate such thing in our young minds, so that they would have their own exploration of the clinical features and be insightful when they take the history or when they look into the signs of the patients. And also, I request them to inculcate communication skills, which is now taught, but still the experience of yours would be great. I thank you all, and I wish all the students the best to learn more their seniors. Thank you, sir.
Thank you very much, Professor Kavita Rajan. I would now like to ask Praveen Selvanandam, who has been appointed as the Secretary of the Student Subcommittee, to initiate the proceedings.
So, thank you, Badrinath sir. Good evening and a warm welcome to all. So, I would like to start by thanking the chief guest for today, Dr. Kavita ma'am, the Vice Principal of Madras Medical College and Rajiv Gandhi Government General Hospital, for allotting time amidst the bloody schedule to attend this meeting. Madam has taken great strides in cultivating a culture of academic excellence, not only in academics, in sports and other extracurricular activities among the students of MMC. Thank you, Madam. I would also like to thank the directors of the foundation, Dr. Badrinath sir, Dr. Kandaswamy sir, Dr. Vaidyanathan sir, Dr. Bharani sir, and Dr. Sudhakar sir, for their efforts to build this foundation as a platform of communication between the senior graduates and the young zealous students of MMC. So, the student cell, as the secretary of the student cell of Madras Redford Doctors Foundation, I hope I will be able to uh, live up to the expectation that the directors have vested upon me, as well as serve my fellow students at MMC. So, coming to the case discussion, this will be happening once a month with one of the students presenting a case and a distinguished expert from the concerned field, along with the directors of the foundation, acting as judges. So, they will be providing their inputs, followed by doubts and discussion. So, for the next month, we will have a Darshan, a second year student, presenting a case from ophthalmology. So, the specific details of the case and the exact date will be announced later. So, thanking everyone once again and looking forward to the presentation. Thank you. Over to Vishal.
Vishal.
Good evening. Good evening, sir.
Vishal, okay. Vishal, let me introduce. I thought Praveen was going to introduce you. Vishal is second year medical student at Madras Medical College, and he has come forward to present the first case in this student chapter.
Sunil, sir. Sunil.
Sorry, Sunil. Sunil.
Yes, sir. Good evening, all present here.
Would you like to introduce yourself before you start?
Yes, sir. Very good evening to one and all present here, the great professors from various institutes and countries, and our vice principal, Dr. Kavita ma'am, the secretary, co-secretaries, and my dear friends, and the seniors who are here to witness the presentation. This is Sunil Kumar, currently pursuing second year MBBS in MMC. So I'm just wanted to, this is our first year in clinicals, and the first case that I saw was about osteoarthritis, and this spoke the interest in me about osteoarthritis, and I just wanted to present a case about it, and I apologize if any mistake is there in the case, and with all the guidance from the great professors, I would like to start the presentation. Can I, sir?
Please do. You can share the screen.
Yes, sir. So the case was a 60-year-old female came to the OPD. She was a laborer and with a complaint of pain in both the knees for 15 years. But in the recent time, for the past 1 year, having a severe aching in the right knee, and which was aggravated during walking. So the history of the presenting illness was on the pain. It was in the right knee with a duration for the past 1 year. It was insidious but non-continuous, dull aching, and there were no referred pain or any radiation. Aggravated on walking and prolonged standing, and it was relieved on medication, not much relieved on medication. So she was undergoing for the medication for the pain for the past 6 months, and she had an occasional swelling on the right knee, which was on stoppage of the drug, which used to be increasing, and there was a early morning stiffness. She had a limping, was able to walk for a few meters without limping, then started with limping followed by severe pain. She had a medical history of hypertensive and was undergoing continuous medication for the past 1 year, and she was not a known case of diabetic, no asthma. She had no trauma, history of any trauma, no history of any fever, no bleeding gums, and no small joint injuries. She was not alcoholic, smoker, and consumed mixed diet. A family history has no relevance in the case, that she does not have any history of occurrence of rheumatoid arthritis throughout her family, and the BMI of her was about 22.9. So the general examination, the patient was found to be normal, and all the vitals were found to be normal. On clinical examination of the lower limb with attitude of the patient in a supine position with extended hip and knee and ankle neutral, were able to find a 10 degree of varus deformity. There was no obvious muscle wasting or gross limb length discrepancy, and to confirm this, We have done with a measurement with the both limb length measurement as well as circumferential measurement. Both were equal and normal on both the sides. So there was no muscle wasting as well as limb length discrepancy. On local examination, there were no sign on the right knee. There were no sinus or scars, but there was a swelling on the infrapatellar region. There were parapatellar hollowness present, but there was no local rise in the temperature. On performing the patellar tap test, it was found to be normal with the patellar bouncing, rebouncing, and I was able to palpate the femoral condyles, tibial condyle, femoral condyle, patella. With that, the medial joint line and lateral joint line. There was a tenderness on the medial joint, and there was a presence of crepitus. On examination of the ligaments, a medial or lateral ligament was found to be normal, but the lateral ligament was having a laxity and was with pain, but she was able to perform the test. Anterior and posterior crucial ligaments were found to be normal, and by doing the movement of the right knee, she was able to do an angle flexion up to 110 degrees, a passive up to 90 degrees, followed by a 20 to 30 degree of flexion active degree. So around 110 degrees of flexion was able to be done. But this movement was associated with pain and restriction compared to the normal side, that is with the left knee. On finding the sensory and other functions, there were no distal neurovascular deficit. So my provisional diagnosis with this history and the examination would be osteoarthritis of the right. So it was requested for a X-ray, weight-bearing X-ray on a long face view with on the right knee with AP and lateral view. So the X-ray which is depicted here is the AP view of weight-bearing X-ray, where the medial side, as you can see, there is no joint gap on the medial side of the knee, and the joint gap is present on the lateral side. So this medial joint gap free confirms the valgus deformity, and also a presence of an osteophyte being present in the part of the tibia. On the lateral side, and also presence of subcondylar sclerosis, there is a much deposition of the bony prominence. On the lateral view of the X-ray of the right knee, there was a much more sclerosis, and the gap between the patella and the femur and tibia was much reduced. When comparing with the complete blood hemogram, it was all the findings were found to be normal. So the case summary would be a 60-year-old female came to the OP with severe pain of the knee for the past 1 year, and she was having a swelling on occasional swelling on stoppage of the medication. She was limping and she was hypertensive earlier, and the patellar test was found to be positive, and other ligaments were normal, and the flexion restriction was being found. And the probable diagnosis is osteoarthritis of the right knee. Some of the managements which I came across with this osteoarthritis are like physiotherapy. So generally this physiotherapy for strengthening the muscles of thigh with joint mobilization like ultrasound, moist heat physiotherapy, interferential therapies, and weight loss. Actually, this patient was not obese. So as the BMI is only 22.9, obese condition, we can use weight loss, which can reduce the weight bearingness of the knee, so which can produce some temporary relief. Whereas medication can be analgesic and NSAIDs can be used, and hyaluronic acid injections are also sometimes given. These are just to increase the viscosity of the fluid and produce a temporary remedy. And the surgery which can be preferred like wedge osteotomy or tibial osteotomy, and now commonly used ones are replacement. So this is my case.
Right. Thank you very much. You did present it well. There were just two things. You made a small mistake. I think you said there was a laxity of the lateral ligament, whereas you couldn't have had a laxity of lateral ligament because there was a varus deformity of the knee. So only the medial ligament would have been lax. Apart from that, I think you did very well. I would go through the whole lot again, just to inform the students how you went about it, and we will go one after the other to see how things are done. Generally, your presentation was okay. I would like to comments from other senior members as to what they thought about the presentation of an osteoarthritic knee by a second-year medical student. Okay, Murli, yes. Murli
Yeah,
is
I
a
thought-
senior neurosurgeon, professor of neurosurgery, New York, and he is at the moment in Los Angeles attending a meeting. Please go ahead, Murli.
Yeah, Badri, I thought the presentation was very good, especially for second year medical student. He did not miss anything. He hit upon all the important positive and negative features in both history and physical examination. His presentation was crisp and clear. And of course, you being an orthopedic surgeon with a specialty in the knee joint, picked out a small mistake, which is to me not very serious. I was impressed. I thought it was a good presentation, and he did not miss anything, and I enjoyed the presentation.
And you
evening,
will give him a pass.
No, better than that.
Thank you so much,
I'll
sir.
do better than that.
Okay. Anyone else?
Dr. Mohan.
Dr. Barney, physician from New York, now in Chennai.
Well, did you examine other joints?
Sir,
Did you examine any other joints?
sir, I found the hip joint was examined and it was found to be normal. I found only examined only hip joint and knee joints with the left knee also.
Did you do any of the lab work for comorbid condition?
No, sir. No.
Can I just interrupt? Barney, you raised a very important point. When patients present with knee pain, quite often, you miss the hip because they do not complain of hip pain at all, and you are concentrating on the knee joint, and you are going through the examination, you're investigating the knee joint, you're completely forgetting the hip joint. And I have known surgeons who have gone ahead and operated on the knee and replaced the knee joint later to find that the whole symptom pain arose from the hip joint. So following the knee replacement, the patient did not recover and she continued to have pain. And that is because the hip joint was the sole problem. So it is most important that you examine the other joints, right? That's a good point, Barney. Thank you.
So I examined the hip joint on both the sides, and it was found to be normal, sir. So I didn't mention it. I'm very sorry, sir. I'll add that too.
Yeah, that's good. I mean, this is more a postgraduate topic than undergraduates. Fine. Yeah.
Absolutely.
Anyone else?
Yeah, I would like to know if you did a MRI on the knee and the results.
Do you need to?
Well,
Actually, yes, sir. But as per the assistant that was given, he ordered an X-ray, and we saw the X-ray. And the next case, I have to follow up with the patient, sir.
Yeah, Chandrasekharan.
Yeah.
If the X-ray shows a straightforward osteoarthritic joint and the patient has got symptoms in the knee joint, we do not need to go for any higher examinations like MRI, CT, etc. We are absolutely sure the problem is in the knee joint. X-ray confirms that, and you can go ahead with surgery. You do not need any other special investigation.
What's the value addition for MRI anyway?
Well, any soft tissue damage.
Well,
There will be soft tissue, some soft tissue damage. There will be some arthritic change. So what? What are you going to find extra that you are not that you need to before surgery?
Well, if you had to do a knee replacement, if it is something that can be cured with physiotherapy and
Yeah,
other
we are
steroids.
going to come to that.
Oh,
Chandrasekhar.
sorry, I jumped on
Okay,
that.
okay. What I'm going to do is to just show you a little salient points. Okay, this is for the students actually. When you examine any patient, orthopedic or neurology patients, you always ask them to walk so that you see the gait, and then you ask them to stand when you can see the deformities. You can actually see the varus and valgus deformities if there are. And then you can measure the valgus angle by drawing an imaginary line through the thigh and the tibia, and the angle at which the line crosses is the varus deformity angle. Similarly, you can do that for the valgus deformity. And here you find the bilateral varus, but here more than the knee joint, you got bowing of the tibia. So there may not be actually arthritic change in the joint. Once you take a full X-ray, you will know whether the joint is affected or it is just the tibia, which is kind of bowed both sides. Then when you see the patient on the couch, you see the knee joint, whether they are able to straighten the joint fully. If they are not able to straighten the joint, there is some amount of residual flexion present, and that is your fixed flexion deformity. They cannot extend the knee beyond that, but they can flex the joint. So this angle is the angle of fixed flexion deformity. So you can say there is 30 degrees of fixed flexion deformity. And these are the things you are going to examine in the knee joint. One, the knee joint is composed of the lower end of femur and the tibia, and both these bones are covered by articular cartilage. You can see the articular cartilage, and that's the articular cartilage which is going to be the problem for arthritis and so on. And you have the two menisci, medial and the lateral meniscus. These can cause problems too. So the problems you can get from the cartilage, articular cartilage, the covering of the joint, from the meniscus, medial and the lateral meniscus. You can get problem from the medial collateral ligament. You can get problem from the lateral collateral ligament. And of course, if the patella is affected, if there is arthritic changes between the patella and the femur, you will get arthritic change, and there will be crepitus, and there will be some changes there too. Now, coming to the examination of the knee joint, you mentioned that there was no ligament laxity, or you said there was lateral ligament laxity. How would you check for ligament laxity? Can you tell me, explain this picture?
Sir, on the supine position of the patient, we'll be having a 30-degree flexion of the knee. And
why would you flex the knee a little bit before you check the ligaments?
So to tighten the ligaments, collateral ligament.
No. If you keep the knee straight and examine for ligament laxity, the knee will be locked by the cruciate ligaments. So you will, even if there is a laxity of the medial or lateral ligament, you will not be able to elicit that because the knee is locked straight by the cruciate ligaments. So to relax that, you have to bend the knee, say about 10 to 15 degrees, and then check for the medial or lateral laxity. So here he is testing it by supporting the lower end of the thigh, putting some pressure on the lateral aspect of the lower femur, and he is stressing by stressing the tibia, trying to take it laterally so that the medial ligament is stressed. If there is laxity, the leg will move further than normal. Similarly, when you go to the medial side, you should flex the joint slightly, 15 degrees of flexion, and then support the knee and do the stress test again for the lateral ligament. Here, he's supporting on the medial side and pushing the leg towards the medial side so that the lateral ligament is stretched. When the patient is on the couch, ask the patient to flex both knee joints, bring the knee joints to 90 degrees, and look at the joint from the lateral side. When you look at the joint from the lateral side, if there is a cruciate, posterior cruciate laxity on one side, one of the leg will be further back compared to the other. So that gives you a little clue as to possible problem with the cruciate ligament. When you are testing for the cruciate ligaments, you are pulling and pushing the tibia forward and backward. You can do that by fixing the foot, by sitting on the foot and pulling the leg forward, which will give you laxity. If there is the anterior cruciate laxity, the leg will move forward much more than normal. Similarly, if there is a posterior cruciate laxity, you will not be able to do that because the leg would already have slipped backwards from the position in the back of the leg. You will be able to reduce the deformity and bring the leg to the normal position. That would indicate possible posterior cruciate laxity. If you are suspecting meniscal problem, you have to do the McMurray's test. The McMurray's test is a little more difficult to explain with drawings and photographs. It has to be done clinically on the table with the patient. You have to flex the knee fully, keep a pressure on the medial side, anteromedial joint line. You keep a thumb pressed on the anteromedial joint line. If you're testing for the medial meniscus, rotate the leg laterally and slowly extend the leg to bring it to a neutral position. If the medial meniscus was damaged or there is a problem, as you bring the legs, as you straighten the leg, you will either get a clicking noise, or you may feel a clicking on the medial side of the joint, indicating that the medial meniscus is damaged or there is a tear in the medial meniscus. Similarly, to test for the lateral meniscus, you reverse it. You rotate the leg internally and repeat the same process, putting your finger on the lateral joint line to check for the lateral meniscus.
I have a short video courtesy by Tim Fraticelli of PT Progress. This might give you some idea as to how the McMurray test is done.
To perform the McMurray test, the patient should be relaxed in a supine position as the examiner firmly supports the knee and lower leg. The examiner will hold the patient's knee at the joint line with one hand while holding the patient's foot with the other hand. With the knee fully flexed, the examiner will internally rotate the tibia and extend the knee while applying a varus force at the knee. Pain or a popping sensation indicates a lateral meniscal tear. To test the medial meniscus, the examiner will place the knee into flexion once again, externally rotate the tibia, and extend the knee while applying a valgus force to the knee. Pain or a popping sensation indicates a medial meniscal tear.
Now, coming to the X-ray, when you're taking an X-ray of the knee joint, you must always ask for the film on a long plate, which means you want to see more than half of the femur and more than half of the tibia. The reason being, you want to see whether there is proper deformity. And before you do that, the X-ray has to be done with the patient standing. So when you request an X-ray of the knee joint, ask them for a standing view X-ray of the knee joint, or mention that you want a weight-bearing view of the knee. When you do that, what you would find is if there is a problem on the medial side, when the joint is worn out on the medial side, the weight will go through the medial side and there is a varus deformity. You will see that clearly. If you don't do this X-ray with the patient standing, you may quite often find that this space, which is completely obliterated here, you may still see a space because the leg is relaxed and the tibia is kind of turned the other way around. So it might give you a false reading that there is still some joint space on the medial side. If you really want to see the damage, you want to make the patient fully weight bear on the joint. Now, once you have you had a patient with a varus deformity of the knee joint, and you started with treatment. The treatment for a varus deformity of the knee joint, if the lateral side is completely intact, you should seriously consider osteotomy of the tibia, upper tibia, and correcting the deformity. You would do that by this. You would take a wedge off the lateral side of the upper tibia and reduce the, once you've taken the wedge of bone off, you can bring the two bits of the bone together, and that will actually give you a slight valgus deformity or a valgus knee and relieve the pressure altogether on the medial side. So you do that particularly when the patient is under 50. When the patient is young, you do not want to think about a joint replacement. You want to do other things before joint replacement because the artificial joints do have a life. So they may last 20 years, 30 years. So if the patient is 30 or 40, you do not want to put an artificial joint which is not going to last for the whole lifetime. So, and then they may require a revision and so on. So we may try and do some bone surgery without involving an artificial joint. So the joint, the type of joint, the surgery that you do in varus deformity is take a wedge of bone, bring the two together and fix the bone like this. So that's what will happen. And you will relieve the pressure on the medial side by transferring the weight to the lateral side. Obviously, if the patient is old and they would like a joint replacement, you may think of doing one half of the joint replacement, a unicompartmental replacement. This is a simpler operation compared to a total replacement, but they have this operation has to be done very precisely because you can make mistakes and they can have problems from this. And if both surfaces are involved, and some people even with part of the joint worn out, if there is only medial compartment involvement, and if the patient is old, some people would consider going for a total joint replacement where it replaces the whole joint.
Now coming to treatment, Vishal, you indicated you will start with anti-inflammatory medication.
You start off with analgesics, aspirin, paracetamol, non-steroid anti-inflammatory medication. So you go slowly, starting with the simplest of tablets, going further. The other thing you would do immediately after you've seen the patient is, if the patient is overweight, you will ask them to reduce the weight. That will make a big difference to an arthritic joint. And finally, if the patient, you need to think about exercises, building the quadriceps, building the muscles around the joint, and mobilizing the joint. So physiotherapy is essential before you start thinking of surgery. And surgery, of course, I have explained to you what the surgical procedures are. Now, I would like the students to come in, ask questions, and comment on this.
Badri, can I ask a question?
Yeah, please do.
So in the history, we were told that this patient is a laborer.
Yeah.
Now, with let's say that you operate on her either with a wedge osteotomy or with a hemi or full knee replacement, what would you tell her about her chances of returning back to being a manual laborer?
Tricky question.
Let's see whether the students can answer.
Yeah. Anyone? I think the most important thing for you students is that you've got to be bold. Doesn't matter what you're going to say. Say it. Whatever you think, say it.
It's better to ask a stupid question than to make a stupid mistake.
Yep. I mean, we've all been in this position. We have been shy, not asking questions, not talking to your teachers. We are trying to get you out of that. We want you to discuss with us. We want you to ask us questions. We want you to talk to us.
Yeah. That's a take-home message. Right?
Obviously, they are not examiners, no, and all are very seniors and help and are trying to help them and guide them. So students, you can ask. Definitely, they will guide you. All of them very mighty seniors who almost before you are born, they have studied the MBBS in MMC. So you ask questions, they will guide you and definitely encourage you.
No takers? Come on, guys.
It's the first meeting. People are maybe in the subsequent meetings. People will talk.
Okay.
Hopefully, the idea of our communication with you, your interaction with you, is for you to ask questions. Doesn't matter. You can ask any question. We can try and answer. If it is not, somebody else will answer. It makes you talk. It makes you discuss. It makes you a little bolder.
Madri, you'll have to go.
Good evening, sir. This is Anbu Anand from final year.
There you go.
I believe someone had put up a question in the chat box earlier. Someone wanted to know how you would differentiate between osteoarthritis and rheumatoid arthritis.
There you go.
Right.
Good
Excellent. Question. Very good question. Okay. First of all, between rheumatoid arthritis and osteoarthritis, the difference is in one, you have inflammation. It is due to inflammation that the joint is affected. The changes which take place in the joint is secondary to the inflammation. In rheumatoid arthritis, the synovium is the main problem. The synovium is active, inflamed, producing a lot of toxins or whatever you call it, which kind of starts eroding on the articular surface. There is also inflammatory tissue growing onto the articular tissue. And so all this is rheumatoid arthritis. And to find the difference between the rheumatoid arthritis and osteoarthritis, you will be able to do that by doing a routine blood screen where inflammatory markers will tell you there is inflammation, and that is why the patient is suffering with the arthritis. And also, there is a lot more fluid in the joint. In osteoarthritis, you will have some effusion in the joint, whereas in rheumatoid arthritis, you will find there's a lot more fluid, and also you will be able to feel thickened synovium protruding on the sides of the joint. Obviously, in early rheumatoid, you may not find this, but even in early rheumatoid, you will find a lot of fluid in the joint. So that's the difference between rheumatoid and osteoarthritis. Again, coming to osteoarthritis, the osteoarthritis can be classified into primary osteoarthritis and secondary osteoarthritis. When you say secondary osteoarthritis, the osteoarthritis is caused because of some primary cause, and the primary cause could be injury to the knee joint, some old infection which has settled and the infection is no longer there, but it has destroyed part of the joint. And those are secondary osteoarthritis. In primary osteoarthritis, we do not know a cause for it. Some people say it is hereditary and so on, but literally we don't know why they develop the arthritis. It runs in families, sometimes affecting the younger people as well, but most often it occurs after 50, 60 years of age.
Can I add
Thank you very much.
Yeah, go ahead. Sorry, somebody else wanted to know something.
I just want to add that regardless of the osteoarthritis or the young man, Sunil, was it? Yes, Sunil. You know, somebody else asked about the differentiation between rheumatoid arthritis and osteo. Anytime there's arthritis, look for the other joints, and that will give you some indication.
Right.
Get some blood work done to make sure that you just don't think it's osteoarthritis. You know, do this for autoimmune disorders, whether it's lupus or mixed collagen disease, whatever it is. Always a good idea to get some blood work done. Like Badri said, inflammatory markers. Besides inflammatory markers, you have other markers you can look for. There's nothing preventing somebody with osteoarthritis having other arthritis also. And Badri, many cases of hips. Raj, you're going to say something, Murali?
No, I'm fine.
Okay, good. Anyway, that's the only thing I just wanted to get the blood work done. Just rule it out, and that's all I have to say. For the young people who are listening to us now. Go ahead, Badri.
Sir, there's a question in the chat box.
Yeah.
It reads that Badri sir mentioned about the viability of knee replacement. What could be the complications of knee replacement in a long-term basis, sir?
Surgery.
Okay, you're going into postgraduate subjects now. Right. The knee joint, the total knee replacement. When they do total knee replacement, you either fix the joint using special cement, bone cement, or you can have joints which are cementless joints where the joint is fixed in such a way that the bone kind of grabs the joints and holds it in place. The bone actually grows into part of the joint and holds it in place. The problems that you can have in artificial joints is loosening of the joint. This is the most important part. If the joint is not, when joint replacement is done, it has got to be done very, very accurately. That is why some of the places now have started using computerized replacement systems so that they get the cuts, etc., exactly right before putting the joint. Because if you put a replacement, if you put an artificial joint slightly tilted or not aligned properly, very quickly it will wear out, it will become loose, it will come out. Because the knee joint is very, very complex. It has got to be absolutely right. The alignment of the knee joint should be perfect when you do the replacement. If you don't do that, if you don't get the alignment right, it can easily loosen in time. The other reason for loosening and problem with the joint is infection. If an infection gets into the joint, it is very serious and it can cause a loosening, and the joint can come loose, and you will end up losing the joint. You may have to go in for revision and so on. These are the problems with the artificial joint. Apart from that, obviously, any of these joints have metal component, and in between you have a high density polyethylene. And the high density polyethylene can wear out if you are not very careful with the joint. Having had an artificial knee joint, you cannot start doing things which you were able to do before you had a replacement, like digging, mountain climbing, etc. People might tell you, the surgeons might tell you, you can do whatever you want after the replacement. That's strictly not true. If you start running, marathons on hard surface with an artificial joint, you are bound to, the joint is bound to kind of wear out much faster than it normally would.
Badri, that's why I asked the question about this patient being a laborer and being able to return. So, since you are an expert in this area, can you tell us, since the students didn't want to volunteer, about the possibility of this patient being able to return back to her previous employment as a laborer?
Now, the most important thing is you have to find out what type of job she does.
They're not going to do marathon, Badri.
Well, it's much. Some of them do much worse than marathons. So the knee joint replacement may not be ideal for them, and you may have to tell them, sorry, you won't be able to do the type of thing that you are doing. Sometimes, if they say that they have to do very vigorous, very hardy jobs, people have even suggested fusing the joint, giving them a rigid joint, which means that particular joint is not of any use, but the leg is very stable. But certainly putting an artificial joint into a laborer, I don't think I would want to do that. If it is possible to do an osteotomy and correct the deformity, that's what I will go for. Even there, the osteotomy takes about 6 to 12 weeks to heal. So you have to warn them that you'll be off work for that length of time. I don't know if I have made it clear, but it is tricky and it is difficult.
This is postgraduate stuff, Badri. Let's pass.
There's one more question, sir. I think with this question we'll finish the evening.
Yeah.
So sure. In that box, in bone replacement, what will happen to the ligaments which are present there?
Sorry, I'm sorry. Can you repeat that? Can you repeat that?
In bone replacement, what will happen to the ligaments which are present there? I think.
Right. Okay. This is exactly the reason why I mentioned about when you replace the knee joint, you've got to be very, very precise. The ligaments have to be preserved when you're sectioning the bone. So you cannot section the bone to put the joint in below the attachment of the ligament. It has got to be above. It has got to be, if it is the femoral attachment, it has got to be below the attachment. If it is the tibial ligament, the attachment of the ligament to the tibia, it has got to be above that. So the precision this is where the precision comes in. So all the bone section is done in such a way that the ligaments are preserved. At the same time, you stretch the ligament to the maximum and you put the joint in such a way that the joint is very stable with no ligament laxity. I don't know if I made it clear.
Difficult for them, Badri.
If I showed it on a picture, I may be able to tell you exactly how it's done, because the ligaments have to be preserved in knee replacement. If you cut the ligament, you are going to have disaster. The joint is going to be unstable. As the patient starts to walk, the knee will give way, and it will be either a varus deformity or a valgus deformity, and it will be very unstable, and it will very soon fail. The joint will fail. So the most important is preservation of the ligament. Some of these surgeons were even preserving the cruciate ligaments. There are some special joints where you can preserve the cruciate ligaments as well. This is not necessary. The most important thing is you have to preserve the medial and lateral collateral ligament. The rest of it is fine. The capsule will take care of the anterior and posterior stability. But the medial and lateral stability, you need intact ligaments. Jayanti wants to ask a question.
There is another question in the chat box here.
Yeah, please.
Patient with early stage of osteoarthritis on one knee have a limping gait pressing on other limb. What are the chances of worsening knee mobility on the dependent knee?
This is where you need to send the patient for physiotherapy, mobilize the joint, get the knee moving as much as you can, and keep the knee moving. Because it is painful, patients will start not using the knee. They will not flex the knee fully, which is not right. What you need to do is to give them the analgesics, anti-inflammatory medication, etc., and send them to physiotherapy and get the exercise going. You really need to get the knee moving. And obviously, if there is minor arthritic change, because it is the beginning stage, you can very well get away with just strengthening the quadriceps muscle and mobilizing the joint. And there are quite a number of patients who have gone on for years with minor arthritis involving one compartment or the other, just by strengthening the muscles and mobilizing the joint.
Sir, I have another doubt, sir. And first of all, I thank Badrinath sir and other directors for giving me the opportunity to present and guiding me on this case. Sir, my question is, when I'm going through backwards for this case, I saw like valgus deformity is more seen in inflammation arthritis and varus is more common in this osteoarthritis. Why is it, sir? Is it common or it's a myth, sir?
What is the question?
So, like valgus is more common in inflammation arthritis and varus deformity is more common in osteoarthritis.
No, that's not true. I'm sorry, it's not true. But quite often, osteoarthritis is very common in Indian women. I don't know why. It is because the way they sit, or I don't know why, but it's very common in Indian women. It's not so common in the Western women. In the West, osteoarthritis of the hip is more common than the knee joint. Whereas in India, I find more women suffer with osteoarthritis of the knee joint. Varus deformity, again, is the reason. When you see a woman who has put on a lot of weight, you quite often see them walking with varus knees, kind of bowed knees, both sides. And it's causing pressure on the medial compartment.
Thank you, sir.
Vishal, you came for a trial run of your presentation, and I did give you a few points, and you got all those points into this meeting today. So what I'd like to tell the students is, if they do want to have a trial run before they want to present it at the meeting, they are most welcome. Talk to your secretary, and he should be able to arrange for some senior member to guide you with the presentation, and then you can do the presentation at the required time.
Actually, sir, I forgot to mention Vishal and Sunil as the co-secretaries. I mean, they are the ones who are scheduling the meetings. I'm just directing them. Like whoever comes forward to me with the case, I'm just directing the person to them. They are the ones who are scheduling the meeting, just for the members to know.
Okay. Yeah.
If anyone wants to present a case, you can either contact to Sunil or Vishal.
Okay.
They will be able to fix a date for you guys.
Good.
I don't know if Professor Kavita Rajan is still with us.
Yes, sir.
What would you say of this meeting, Prof?
Yes, sir. Yes, thank you very much for guiding our students. Even before and after, like during the presentation. My observation is that for a second year student, the history taking can be probed more. Like if they say knee pain and of whatever duration, what are all the differential diagnoses they will think of for a knee pain, so that they will probe into the history more, what all they can take from history taking. During the second year, maximum of history taking will help them, right? So this is my observation, and I thought that that will help them more into the basics of patient approach and also develop the communication. Then examining of the patient will be the next priority, and prevention aspects. As the student, of course, the other students of final year are also there who can be addressed, but still these basics are not being addressed, and the students are not knowing the importance of those things. So that and they will also, like, just by asking what are the causes of knee pain, what they have thought now, They will know all the features that can cause the knee pain, and so it will be a recollection of the subject, and they can probe into each one, and maybe say prevention or something, whatever you would advise. We can ask like a micro teaching at the end of each session. Ask them to communicate to the patient regarding any one aspect. It can be either getting consent for a surgery, or it can be either what preventive aspects have to be done, or what exercises, or to lose weight, what can be done, anything that you're going to suggest. They can give a narration of what they would, or they can think you as a patient and then narrate what all has to be done. So that will improve their communication skills. So these two only I just wanted to stress upon. The rest of it went well. Thank you.
Thank you. Thank you very much. I think you raised a very valid point. We were trying to go into all kinds of details. You have reminded us that we should try and keep it at the basic level and concentrate more on the basics than going to the
And even
specialization.
the differential diagnosis also, sir, can be asked, like, so that like they asked about rheumatoid arthritis, all the differential diagnosis will give them, because now you present something that is 5 points or something for that particular diagnosis, and that is finished. But not all cases will come with those salient features and will directly take us to the diagnosis. There are so many things which we have to work on, think about it, what questions we would ask them, what are the leading questions, what are the leadings, what are the questions that is open-ended to the patient, how they will interact with them, and get this history which you have got. Then you'll go into the whatever you have said, sir, the anatomy of it, how you will go into the examination of each aspect of the knee joint. Then the diagnosis will be the least important part of our discussion. Then the clinical history taking and will be better.
Thank you. Thank you so much. Very useful information. And I hope you'll be able to guide us with further.
You're all seniors, but then.
No, I think we tend to miss out on the basics and we go into the higher level, which is not right. From the medical students' point of view, I think we need to come down to a lower level.
Yes, sir. At least 10 questions with the history taking will definitely make them have a thinking mind, rather than just giving them the information and then into the diagnosis and then going into the details of treatment. Probing into the history will be more important for them later also.
Thank you very much. Thank you. I hope you'll be able to guide us as well. So with teaching the students and trying to keep them. One of the things is communication. I think we should improve their communication skills. So by interacting with us, by talking, they should be able to do that. All these are important things for the medical students.
Yes, sir. So whatever answer you want to say, you ask them to say it by asking few questions.
Right.
So you can ask them, like, say, when you wanted to bring out inflammation, then we have to, like, say, ask them what are the markers of inflammation, what are the tests that you will do, what is the sample that you collect, when will you get the result, what is the turnaround time of it, at what time will you go to the next investigation, or will you do all the investigations together. So for interpretation, what are all the other departments with whom you will coordinate? Is a rheumatologist has any role? What are all the interlinked departments whom, and what role do they play? What is the role of a physiotherapist? What is the role of a general physician in that, like that? Or what's the role of an anesthetist if it is going to be? What are all the things that you will look into it? There are so many aspects of this which can become.
Excellent. I think you should come to all our meetings.
Yes, sir, definitely. We actually, all clinical society meetings I do attend in our college. It's organized. We, of course, I don't talk there, but then here I'm just trying to, I'm just trying my students to do all these things.
Okay.
Good. Very nice talk.
Excellent. Very good. Thank you very much.
Thank you very much, ma'am, for being here in your tight schedule and spending your time in complete meeting. Hopefully, we will change all this with the directors concerned and have that the next meeting.
Yes, Sunil, that is what I have been trying. Actually, sir, I'm just sharing. Sunil has been coordinating with the preparation of case vignettes by the students each week and posting them. 4 case vignettes they have been posting every year, and they've done with some improvement in it. So, like that, little things we try, and we are trying to make them more involved in the teaching learning.
Thank you. But I think you should persuade them to talk. They're all very quiet, very shy. They don't want to come
No,
out
sir.
and
It
talk.
is like we have to ask them questions so that they'll come up with answers.
Right.
And like some little things will definitely bring them in line. So even it can be asked as to the presenter or to Praveen or to Vishal, and then we can go.
Okay. Thank you very much.
Thank you, sir. Thank you.
So Badri will have to prepare questions from.
Okay. Yeah. Right. Yeah.
No, sir, it's very simple thing. Like you ask them, how did you ask about the history of knee pain? What are the
Right.
questions that you
Yeah.
asked?
Yeah.
Was it open-ended or was it leading questions? That itself will give them, these things will come out with an answer who is presenting.
Excellent. I think that's why I mentioned that you have to guide us as well as the students.
Yes, sir. Yes, sir. Yes, sir. We
Yeah,
can.
thank-
Yes.
Thank you. Thank you, Doctor.
Thank you. Thank you, sir.
Okay.
If there's nothing else, I would like to ask Dr. Mohan, who is a cardiothoracic physician in London, to propose a vote of thanks.
Thank you so much for having us. That was a superb meeting. And it took me back with the help of Badri on my basics and at the same time advances in orthopedics, including the knee part of the orthopedics. So that was good indeed. And I'll, in fact, to be honest with you, I'll definitely go back to the recording and then go through all those salient points again for me to become a bit more familiar with the do's and don'ts. Because one of the things that we find in life is, as we get along in years, don't I know that better than anybody else? We all have a certain level of joint involvement in various parts of the body. And to be able to get some kind of a clarity on how to go about it is so important. So many thanks indeed, Badri. But before I say anything more, we'll go on to Professor Kavita Rajan. And we are so pleased and so glad that she was part of our journey, which is part of the youth improvement program that Badri has set up so well indeed. And this youth improvement, I think, is a major way forward in youngsters in medicine, because medicine is a learning curve. Nobody knows it all and nobody doesn't know it all. So let us learn, gain, and share from each other, including from Professor Kavita Rajan. You know what they say of a truly great teacher? They say, firstly, a truly great teacher is hard to find. Secondly, they're difficult to part with. And most important all, it is impossible to forget them. So I would classify Professor Rajan in that category, and then taking on some of her important points to take home as take-home messages are balance. Nothing to do with osteoarthritis, but the balance in medicine. Secondly, exploration. She put it across so well. Thirdly, an insightful history. Now that's a splendid terminology. Insightful history means it almost reveals a whole lot to us. Thank you so much, Professor Kavita Rajan. 10 questions, and maybe in one of our meetings, she will enumerate all these 10 questions to us. And then, without a doubt, communication skills. That's where a good doctor differs from a not so good one when dealing with a patient. Communication skills. Prevention is something that we all need to go into. Badri presented about the difference between the Asian women and the Caucasian women. Maybe we need to look in terms of prevention into there as well. And finally, but not fully, differential diagnosis, as Professor Kavita Rajan said. So firstly, thank you, madam, for coming to the meeting, for being a mentor, and please become part of our support system and guide us for the future, because somebody like you will know exactly when to hold the students back and how to get them into going forward without being shy or timid or anything like that at all. So once again, our grateful thanks to Professor Kavita Rajan, and we'll look forward to seeing her in all of our meetings, if not as many as she can attend. And to show our appreciation, we will, can I put it in Tamil? I'm sure all of you know Tamil. We will now show our appreciation by profusely clapping our hands. Thank you, Professor Rajan.
Until we see you next. Thank you.
Thank you.
Thank you, madam. Thank you, madam.